here, and Dr. Priscilla, Dr. Ramesh also is here. Let us just start. Go ahead and let, participants will join. And then
So how many more are we expecting?
we at the most we are expecting around 10 only.
10 more.
And no, not
Yes. Shall we begin, Moon?
yes, Anusri, let's start with the introduction.
All right. So, good afternoon to everyone. A very warm welcome from ITech India. Welcome to our distance learning. So today's is the refresher cum training workshop for OST Center staff. And I welcome our speaker for today, Dr. Arpit Parmar from AIMS, Bhubaneswar. Over
You are muted, Anushri. We are not able to hear you.
Right. A very warm welcome and greetings from ITech India. Thank you for joining us for our distance learning seminar series and for our OST virtual refresher. I would like to welcome our speaker, Dr. Arpit Parmar from AIMS, Bhubaneswar. So, Dr. Arpit, over to you now.
Okay. Thank you, Anushri, and thank you, Moong, for this opportunity. Unfortunately, Dr. Amit could not join today because he has some important work to do, and he had asked me, so I am going to take today's session as well. So maybe before starting, I guess we have around 5 or 6 participants. Let us have a brief round of introduction about yourself, where exactly you are working, for how long you have been working with the OST Center, and whether the OST induction training you have attended or not attended. So those kind of details, if we can share, and if you are okay with it, and if your internet permits, it would be great to see you guys, your faces. So if you can turn on your camera as well while speaking, so it would help me better identify with you people. So maybe we can start with your introduction, and in next 5-10 minutes we'll start our presentation, and then we'll take question answers. So shall we start? So maybe we'll start with I guess Dr. Ramesh. If you can provide your brief introduction.
I am Dr. Ramesh Thawai. I was I am orthopedic surgeon. I have retired from my state government job, and then I have joined. Sorry, my video is not getting on.
It's okay, sir. Please go ahead, sir.
I have been working since 2013 in OST Center. My OST Center is in Chhattisgarh, Korba, and that's I think all.
Okay. Thank you, sir, and very warm welcome.
Thank you.
Who is next? Dr. Vibhuti Nath. Sir. Can you hear us, sir? Dr. Vibhuti Nath?
Hello.
Yes, sir. Please go ahead.
Okay. Myself, Dr. Vibhuti Nath. I am in the Department of Medicine Assistant Professor. Come in charge Nodal OST Center. Yeah. Hello.
Yes, sir. We can hear you.
Yeah. Any other information?
Okay. Thank you, sir. Thank you and welcome.
Thank you.
Then we have Dr. Ashok.
Yes, myself, Dr. Ashok Sinha. I am OST in charge in RMRI MS Sagam Gua Patna. I am working here since 2013, but in this field I am working since 1993. Oh, 1990. I am also a technical expert of Bihar in this field, and I am master trainer of Government of India. So, anything if you want to know from me, I will help you. I
Thank
am
you.
most senior most man of in this field. Okay, since 1993 I am here.
Sir.
When
It's
OST
great
has
to have
not
you here.
started. At that, yes.
Sir.
Okay, sir.
So welcome, sir. Then we
Thank you.
have Dr. Praveen.
Mr. Praveen is from ITEC India. Maybe Mr. Mahesh could go next.
Dr. Mahesh, if you can hear us.
Yes, Mr. Praveen is from ITEC India. I request Mr. Mahesh. Yeah.
Okay. Dr. Mahesh.
Hello, I'm Dr. Mahesh Shimram. I'm a psychiatrist. I've been working at Sadar Hospital, Jamshedpur, East Singhbhum. And I'm not in charge of OST Center, but since I'm the psychiatrist over there, so I've been told to look after the OST Center.
Sir.
Okay, and I think I'm the newest member. Sir told he's the oldest member. I think I'm the newest member in OSTs. I've been trained at CIP. I'm an alumnus of CIP and RENFAS. I've been working in, I was doing a private practice, and I've been working in the Sadar Hospital since the last 3 years, and I've been looking after the OST, not exactly looking after the OST. It is run by the people over there, and they've asked me to see those patients who's come now.
Okay. So it's great to see you here, sir, and welcome.
Thank you.
And then we have Dr. Munish.
Myself, Ramesh. Myself, Ramesh. Sir. Mahesh.
Dr. Munish, can you hear us? Dr. Munish Bhagat, I guess, if I can read your name and pronounce it properly. Dr. Munish, can you hear us? Okay. I think, okay, we have another doctor joining, Dr. Omkar Lal. Can you hear us, sir?
His audio doesn't seem to be connected yet.
Yeah, it's now connected, I guess. Dr. Omkar Lal. Sir, can you hear us?
I don't think he's connected. I can't see the audio sign.
Okay. So I think we can start now. So before starting, can we have a screenshot or a photo of all of us together? And then we'll start. Just for a moment, if you all can turn on your video.
Yes.
Just for a moment. So Anushri would be taking a click, right?
Yes. Praveenji, please take the screenshot. Let us know once you're done, and then we'll carry on with the session.
Yeah, I'm still waiting for more people to switch on their video.
Sure.
We have Dr. Vibhuti, then Priscilla, Dr. Omkar, Your voice is breaking, Anushri. We can't hear you if you're trying to say something.
I didn't hear.
We can't hear you, Anushri.
Can't hear you, Anusha.
Also joined us. Brief introducing everyone to OPEC vintage order. So if you can hear me, I'm requesting. Yeah, carry on, carry on.
Okay. I think it's taking a lot of time. Maybe we will just take a screenshot and we'll move ahead with the session. Praveenji?
Yeah, will it take it, sir?
Yeah. Okay.
We will continue. Yeah, thank you.
Okay. So today's session is more about kind of a follow-up session. You all must be aware of the OST, it's NACO's specific guideline has on it, and many of you might have undergone the training for the same, the OST guideline. Some of you are already master trainers who are working for a long period of time. So these are just things which are kind of known to you, and we'll just be discussing it for a very short duration, and we'll have some question answers, any kind of clinical queries if you have. If I would be I'd be happy to answer and try to take care of all of your queries, questions. So we'll have around 10-15 minutes of presentation first regarding the major aspects or major clinical things which everyone should know about buprenorphine when they are prescribing the drug. And then we'll move on to various case scenarios and finally questions and answers. Okay, so is my screen visible to all of you?
Yes, sir.
Okay, and it's on the presentation mode, right?
Yes.
Yeah. Okay. So what we would be talking about is in very brief about the opioid substitution therapy. What is the philosophy behind the opioid substitution therapy? Some pharmacological properties of buprenorphine. Whether buprenorphine fits the bill for an ideal OST medicine or not, and then we'll talk about some case scenarios. So first of all, what exactly is the opioid substitution therapy? Why exactly we are prescribing this medication? You all must be aware that many misconceptions or myths are there among the common lay people, their family members, that when we are prescribing this particular drug, we are kind of just replacing one kind of drug with another drug, or maybe one kind of nasha to another nasha, right? And it's a very, very, very common kind of an understanding of our clients or their family members, and it creates a kind of a roadblock when you are dealing with those clients, and that is associated with issues with the retention or the overall efficacy of the medication. So why exactly it is not a nasha? That is something we all need to understand, and many of these aspects we already know, right? When we are talking about morphine or heroin, the kind of recreational drugs people, opioids people use, they are illicit in nature. On the contrary, when we are providing them with agonist medication, which are quite legal, illicit substances have their own kind of complications, like they are not very uh, made very good chemically. There are other substances, there are very many impurities, so we are not very well aware of their complications or their medical safety. On the other hand, when we are providing with buprenorphine, it's a medical grade compound, and we exactly know how much of buprenorphine we are giving, and a very safer route through which we are giving the medication. On the other hand, when they are using substances, it is something through which something which is very unsafe route. Most majority of them, they are the injecting drug users. Again, when people are taking heroin or morphine, or even buprenorphine by injecting route, they are short acting, which means that their entire day or a typical day looks like they take, say for example, they take the substance at 9, around 2 hours they will spend under the intoxication, then next 2 3 hours they would be recovering from the intoxication, then the withdrawals would start, they have to again take the heroin dose, and then again the intoxication will occur. So in a day they have to use it 3 4 times, and most of the time is spent under the intoxication or in recovering from the effects of heroin or morphine or during the withdrawals. And hence it is almost kind of impossible to focus on other things such as your personal life, your family life, your social life, etc. On the other hand, when we are providing medication as a opioid substitution therapy, we are choosing a medication which is a longer acting. So you give it in the morning and the patient is completely fine 24/7. He is not going to experience withdrawals, craving, or other issues if he is on a stable or the optimum dose of buprenorphine medication. Again, morphine, heroin, they are more kind of addictive drugs. On the other hand, when we are giving buprenorphine, it is an agonist medication of known purity and the potency, uh, and which is given by the sublingual route, which is much safer than the injecting route. And uh, something which we do not emphasize much while we are dealing with our clients is that we are not just providing a medication. It's not that the patient has to come, take medication, go away. No, we are also providing them with the psychosocial intervention. So OST is much more than just providing the medications. It is something which is provided under the constant supervision of the doctor, nurse, counselor, along with multiple psychosocial interventions. And hence, this is not something to be equated with drugs or nasha per se. So this is a very common misconception, and which needs to be kind of dealt with efficiently. There are some pharmacological properties of buprenorphine which needs to be talked here. Uh, you are all aware of naltrexone, which in an antagonist, it doesn't have any opioid effect as you can see in the graph. But what it does is just blocks the effects of any opioids you administer after taking naltrexone. If you see opioid agonists like morphine or heroin, they have a very clear slope, which means that the opioid, with every increase in the opioid dose, there would be increase in the opioid effects, right? So there is no plateau of these effects. On the other hand, with the partial agonists like buprenorphine, after a certain dose, there is a plateauing of the opioid effect of buprenorphine. And hence, because of this, uh, at a lower dose, buprenorphine acts as a full agonist. At a higher dose, it acts as a partial agonist. And hence, further increase in dose will not have a further increase in the effect, and it is safer in the overdose as well. This is known as ceiling effect. So that is why buprenorphine is much safer as compared to morphine, heroin, and is very minimally associated with overdose deaths. So what are the clinical implications? I already mentioned that there is a very less risk of respiratory depression even with the higher doses of buprenorphine, and then there is a lesser chances of death due to overdose. Again, buprenorphine has a very high affinity to mu receptors, mu opioid receptors. You all are aware that most of our opioids, they exert their euphoric effects or the intoxicating effects through the mu opioid receptor agonistic actions. So what happens because of this high affinity, if someone is already on buprenorphine, all the receptors are already occupied by buprenorphine, and hence buprenorphine will not allow any exogenously administered opioids to act, and hence there will be no euphoria, no action of whatever opioids you are administering on top of buprenorphine. On the other hand, if someone is taking other opioids. Say for example, someone is taking heroin right now, he is intoxicated, and you give them buprenorphine, what will happen? It will displace heroin from its receptor, and hence buprenorphine would be able to produce its own effect. So what are the clinical implications? If someone is under the influence of heroin, you administered buprenorphine, buprenorphine will displace the heroin suddenly. There will be a partial agonist action of buprenorphine. But what will happen? The person was initially on the full agonist action of heroin. Now he suddenly crashes to the partial agonist effect of the buprenorphine. And hence, there will be a sudden decrease in the euphoria or whatever opioid effects were there, and then there would be precipitated withdrawals. And hence, every time when you start buprenorphine, the first thing you have to check before giving it is that whether the person is under intoxication or not, and ask them whether they have taken heroin or other substance, other opioid in last 4 to 6 hours. If they have taken it, you have to wait for maybe for next few hours until the withdrawal symptoms emerges. Once the mild withdrawal starts, you can give the buprenorphine medication. If, as I already mentioned, if an individual is on daily dose of buprenorphine, if someone consumes heroin, say for example, on top of buprenorphine, buprenorphine will not allow heroin to act, and hence there will be no intoxication with heroin. The person won't feel like taking it again, especially when it is on, he or she is on buprenorphine. This particular effect is known as opioid blocking effect. What is something important here is that this opioid blocking effect is our major clinical goal when we are starting anyone on buprenorphine. We are not starting them just for the management of withdrawals. We also needs to take care of the craving. We also needs to take care of the exogenously administered opioids as well. So at a lower dose, there is no blocking effect at all. But with the optimum dose, when you go a bit higher, the blocking effect will be seen. So with the low, we usually say that around at least 4 to 6 milligram is required for the management of withdrawals. Slightly higher dose, around 6 to 8 milligram, is required to take care of the craving part, and a further slightly higher, around 10 milligram or 12 milligram of dose of buprenorphine is required to also see this opioid blocking effects. So for most of our clients, the average dose should be around 10 to 12 milligram when we are using buprenorphine as a maintenance agent or a substitution agent. And smaller dosage might be used when you are using it just for the withdrawal management purpose, which you commonly say as a detoxification agent. But the goals of detoxifications are completely different. So we are just taking care of the withdrawals there, and then we taper it down. On the other end here, the goal is not to taper it down. So we need to take care of not just withdrawals, but also craving, also the effects of exogenously administered opioids as well. Then buprenorphine has a very slow dissociation from its receptors. Because of this, its terminal elimination half-life ranges from 24 to 37 hours. And because of this, it has a very long duration of action as compared to the other opioids. What are the clinical implications? If you see the clinical effect again of the buprenorphine, the low dose of around 2 milligram has effect only up to 12 hours. On the other hand, high dose 10, 12, 16 milligram effect might last up to 48 hours. So when the client is not being given the sufficient or the optimum dose, has been maintained only on 2-4 milligram like that dose, the effects won't be lasting for 24 hours, and hence the patient will have withdrawals. He will ask for more dosage, maybe he will be taking another substances. And because of this high dose, the effects last for up to 48 hours, we can administer this drug as a single daily dosage. No patient needs to take this medication on 2 or 3 divided doses at all. It is not clinically required. All the patients, whether they are on daily dispensing or they are on weekly dispensing, it has to be given on a single daily dose matter only. Now, the bioavailability. Many of the patients you might see that you keep on increasing the dose, but what happens that they are not having any effect on their withdrawals. The withdrawals are similar even after increasing the dose. Sometimes what happens that they are not taking it very properly. The oral bioavailability of drug is only 10%. So if you keep on increasing, if they are not taking it properly, then the effects won't be there. You might need to go for a very low, very high dose. On the other hand, with sublingual, almost 50% bioavailability is there. And with sublingual, the half-life is almost 27, 28 hours. That is why when people inject buprenorphine with injection, the half-life is only around 3 to 4 hours. So most of our clients, they inject buprenorphine every 6 or 8 hours because of this less half-life. When we come to the contraindication, the only contraindication per se is the hypersensitivity to buprenorphine. You might not give it at all, but it's a very rare kind of a thing. And we, in my 10 years of addiction medicine practice, I have never kind of come across any client who was hypersensitive to buprenorphine. Uh, Use with caution, especially when other kind of CNS depressant drugs are being taken by the client, like hypnotic sedatives, benzodiazepines. It is quite common uh, in our patients. Alcohol, there is a risk of respiratory depression. So maybe you might want to go a little bit slowly with the increasing the doses of buprenorphine. Then there are other conditions like respiratory impairment, asthma, COPD is there. There might be a bit risk of respiratory depression, hepatic impairment. The blood levels might be erratic, and you might have to change the dosage frequently. Regarding the drug interactions, by and large, it is safe. As I already mentioned, if there are other brain depressants, you might consider a slow increase in the dosage of the buprenorphine. If they are on opioid agonist, may cause precipitated withdrawals. There are some common medications which actually induce cytochrome P453A4 enzymes, like antiepileptics such as carbamazepine, phenobarbital, phenytoin, ATT or ART. So it is not so uncommonly seen that patients, when they are on OST and you start ART, they start experiencing withdrawal symptoms. It is not that they just want to increase that dose, but efavirenz or nevirapine, which is part of the regime, it actually kind of decreases the blood levels of buprenorphine, and in such clients you might have to increase the dose of buprenorphine. Then there are other drugs which kind of increases the blood levels of buprenorphine, and hence so if some of the drugs like antidepressants, if you are starting antibiotics, antiretroviral, suddenly you might see your patient are becoming sedated or drowsy after giving the same dose of buprenorphine. It doesn't mean that they are taking other substances or something, but it is just the other medications which are kind of interfering with the metabolism of buprenorphine. So you might have to decrease the dose a little bit for some time till these medications are continuing. $1 million question: whether buprenorphine has dependence and abuse potential. The answer is yes, definitely it can be abused, especially people who are not dependent on opioids. If they have no tolerance, it might cause euphoria. However, most are not most all the patients, they have already developed tolerance, and we are providing through the sublingual route, and your most of the clients would not experience any euphoria. We are yet to see any client abusing like heroin this buprenorphine by sublingual route. When they are kind of misusing, it is primarily through the injecting route per se. However, we also need to remember that its abuse liability is much less as compared to heroin. So whether this is an ideal OST medicine, what should be an ideal OST medicine? One, the foremost thing is that its action should be similar to the illicit opioids. So it should be agonist, which could control withdrawals and cravings similar to illicit opioids. And when you see buprenorphine, it takes care of the withdrawals and craving in a very amazing manner. It should have a lesser addiction potential. Definitely, buprenorphine has a very less addiction potential as compared to your heroin. It should be easy to administer. We are providing it through sublingual route. Action should last for at least 24 hours, right? And it should be well tolerated with minimal side effects. So, if you see closely, all these criteria are actually met by buprenorphine, and hence we are widely using this particular medication for our clients. So, this is just a brief overview of buprenorphine as a medicine, its some pharmacological effects, and now we have some clinical scenarios which we commonly encounter, and it needs to be answered. So let us have some interaction about these clinical scenarios. I'd like to have your own views on that, all of these scenarios. So the first scenario is a client argues that earlier I was addicted to heroin and now I'm addicted to buprenorphine. Uh, do you think you should defend the OST intervention that is being provided to the clients, or it is something okay to not kind of clarify this particular doubt? Can we have some comments, suggestions, or how do you kind of deal with this particular problem in your clients? Anyone, if anyone can share. How do you take care of this particular issue in your clients? Anyone?
Myself, Ramesh Thawai, sir.
Sir?
Yeah, I used to tell them that no, you are not addicted to buprenorphine, but you are just having no withdrawal, no craving, which you are having in opiates, other morphine. And second thing, you are not abusing anybody. You are not on high anytime. So your concept is not correct.
Okay. So you would like to give an example that there are no withdrawals, no craving, you are not
Right.
abusing in a very unsafe manner, and hence,
Right.
yes. Anyone would like to add something or would like to differ on anything? Anyone? Anyone else? I think we have Dr. Ashok sir, who is a kind of a very experienced person in this field. If he can share his experience, how to kind of better deal with this particular issue, because this is something very common across India. Everyone feels that we are just providing one form of nasha. So, sir, what is your view? How can we deal with this particular question?
First of all, I will take his all history about heroin, how much time you have taken, how many days you have taken buprenorphine in injectable form. I will calculate him all the drugs on that when he has taken the buprenorphine, how much day, how much withdrawal, and then I will give them the drugs about that. Only on buprenorphine, not by the you are taking earlier. You have taken the heroin from 5 years or 7 years. Nothing. I will only calculate how many days you have taken the buprenorphine just, and I will calculate from that. Okay.
Sir. Okay. Okay. Anyone else would like to add something or would like to agree, disagree? This is a open
Hello,
discussion.
sir.
Everyone, yeah, Dr. Mahesh, please.
Sir, the person was taking was addicted to heroin, and now he says that he is addicted to
buprenorphine. So we have started buprenorphine. He is stabilized on buprenorphine, but he still thinks that पहले तो भाई मैं हेरोइन पे नशा कर रहा था, अब आप लोग buprenorphine दे रहे हो, मैं उसको ले रहा हूँ, मैं उसका नशा कर रहा हूँ, है ना? ये बहुत कॉमनली बताया जाता है मरीज के द्वारा. मरीज को भी लगता है ये नशा ही है एक तरीके का. सो उसको हम कैसे डिफेंड करेंगे? भाई हम नशा नहीं दे रहे, हम एक दवाई दे रहे हैं.
So, sir, we would like to know whether he would like to quit the different form of nasha which is taking according to him, because the person now is on psychological dependence. He is on psychological dependence rather than a physical dependence, which I presume, or we can say that. So why not taper the buprenorphine if he's not having any, and why not go for complete abstinence?
Okay. Okay. So you say that in such clients, it would be better to we can taper the medication. Am I right in?
Excuse me.
We'll come back to that particular issue, whether we should taper it, whether when to kind of taper it, when to stop it. We'll definitely come back to it because we have another question on that. But
no.
Here,
1 minute. 1 minute. I have already done tapering the dose of the patient just, but still I have not get any result from that. I have not get, but because I have given the pay, now some patients are on 0.4 milligram. They are psychologically depend on that, and I have counseled him so many times, my counselor myself, but still they are on 0.4 milligram. That is very important. How I will do that? So I have started. I have started one thing that I told them that you will take 0.4 milligram daily. Then after 1 week you will start from 0.4 milligram alternate day. Then you start from a gap of 2 days. So by this I have got result. When I say about 100%, if I had 10 patients of that, now 4 patients are out of. They are left the drugs, and 6 patients are now also taking 0.4 milligram. Still they are taking. They are still taking. So I have done these things also already have done.
So that's I said we'll definitely come back to the question of whether buprenorphine should be stopped. If stopped, when it should be stopped, and how long it should take. We'll definitely come back to it. We have another scenario for that also. But here, what we kind of usually what information should we give to our client so that this particular myth is taken care of, because this myth is a very common that भाई मैं तो नशा ही कर रहा हूँ, अभी भी buprenorphine आप जो खिला रहे हो वो भी तो नशा ही है ना? So what we usually do and what we have found it to be quite effective is a comparison of, if the client is already on buprenorphine, a comparison between his life before starting buprenorphine when he was kind of taking heroin for a long period of time as compared to his life currently, that how he was spending maybe almost 24 hours on his substances how he was not able to take care of his responsibilities of family, his personal life, his social life. There were issues in maybe job, maybe work related issues, and he had to spend a lot of money on that. On the other hand, we compare his life right now, that there are uh, no more familial issues or very less familial issues. He's able to work, he's kind of doing well in his work, he's able to provide money or provide for his family members, he's able to spend time with his family members. He has reached probably as much normality as other persons, except that he has been taking medications. And this comparison, that your life was like this before, it is like this before now, and there is a stark difference between them. So this is something which we commonly do in the scenario. And the first slide we talked about, right? Why it is not a nasha or a drug, it is a medical intervention. Just like we are giving insulin to diabetic patients or anti-hypertensive drugs to patients with hypertension, this is also one medication which we are providing for this particular scenario. It is not a nasha. We are giving it under a very our own supervision. We are asking you to come daily or once a week. We are providing you counseling. So this is much more than being a nasha, right? And again, we ask a very simple question. Do you feel that euphoria after taking buprenorphine? Out of 100 or 200 patient, maybe one patient will tell you that लेने के बाद थोड़ा नशा सा लगता है. And when you ask कि भाई ये नशा क्या है, किसको नशा बोल रहे हो, they will say थोड़ा drowsy लगता है, नींद सा आता है. And then you will ask whether this is the same nasha because of which they were taking heroin, and they will say no, definitely no, it was the euphoria which they are looking for, and there is no euphoria at all. So the definition of nasha for them is also different when it comes to buprenorphine. So you might have to take care of all these little misconceptions also while providing buprenorphine. So I hope I'm a bit clear on this, that we have to very empathetically say that no, this is not a nasha, this is a medication just like any other medication. If your patient is suffering from diabetes, give him an example that you have to take insulin daily for a long period of time. If you don't take insulin, the day you don't take, your glucose level would be disturbed. The same way you are taking buprenorphine, maybe if you don't take it, there would be some withdrawals. Definitely there would be some withdrawals. But does it mean that you are dependent on it? No. It is just some sort of physiological dependence and not the addiction as an illness per se. So this is what probably we have to tell our clients. Okay, the second case scenario is, which probably we were talking just some time back, a client who was dependent on heroin is currently receiving OST. He is on OST treatment for 6 months and now believes that he has recovered from addiction. He desires to stop the OST treatment as well. How to proceed in this case? So what do you think? What should we do? A client is on OST, he's doing well now. 6 months, he believes he has recovered and he wants to stop the OST medication. What should be your clinical opinion here? What should you do? Any answers, any opinions, any comments on this? How would you go ahead?
I will not stop suddenly the medicine of OST. Because
Okay.
patient has said that I am recovered from the addiction, but I will not stop the medicine immediately. You will tell me that I am fine, sir. I don't like to take the medicine. No, we will continue. And if he want to stop, then I will start tapering of the dose. From the convenient of the patient and myself. I know that he has on 8 milligram. Now say he has on 8 milligram. I told them that don't stop suddenly 8 milligram. You will start from 8 to 6 milligram. You will continue for 6 milligram. If you will feel better, No, sir, I am, this is, my dose is too much. Then I will start after 1 month or 2 months. I gradually reduce the dose from 6 to 4, 4 to 2, like that, and gradually I have stopped the medicine, not exactly. Then I came on 0.4. Just I am doing so. I am telling, come to 0.4. Then I have started alternate day, then 2 days week, then 3 days, and then again gradually has started. I have already 40% patients my recovered from this method. I have done this one, so I have told you. That's all.
Okay. So two things which you said, that in this particular client you would not stop right now. You would assess him more, and then based on that you
Yes,
will decide. And once you
yes.
decide, you will taper it down quite slowly, not very suddenly.
Yes.
Definitely.
No.
Any other doctors who would like to say something here? Any?
As you told earlier, that
Huh.
as it is medication like diabetes and hypertension, I used to tell them that you are, if because you are taking buprenorphine, you are feeling that you are free from addiction. It is not, you are not free from addiction. If you will stop this medication, you will again have craving and withdrawal symptom. So better remain with this for more than for about 6 months more, and after about a year, if you want to, if you are prepared to taper dose, if you are prepared to close this, then I will start tapering.
Okay, so your point is that again, right now it should not be stopped
Right.
because buprenorphine is being given regularly. He feels that he has recovered, but you feel that recovery is much more than that, right? It
Right.
requires
Right.
much more than that. So maybe you want to wait for 6 more months and
Right.
then assess again, and based on that assessment, it will be decided whether to stop or not.
Right,
But
sir.
you also agree that it should be tapered over a period of time and not stopped suddenly, right?
Right, sir. Right.
Okay. So any more opinions on that? Anyone else? Anyone else? Anyone else would like to add anything or say something which is probably not shared by other people? Okay. So here I would like to share at least 3 or 4 things which I think everyone of us should take care of, or should take keep in our mind while we are providing opioid substitution therapy. When it comes to the duration per se of opioid substitution therapy, we are not very clear for how long it should be given. But the majority of the studies, or not even majority, almost all the studies say that OST should be continued for as long as possible. That is one thing. It has to be continued for a long period of time. It is not about few months. It is not about 6 months, 12 months. It is not like TB where you give it for 6 months or 1 year and your course is over. You are fine now. You have recovered from addiction. No, that is not the case. It has to be continued for a long period of time. Even for some clients, the buprenorphine you might have to give for 5-10 years or even lifelong. So that is one important thing, that we cannot decide based on just the duration whether the person has recovered or not. That is first thing. Second important thing is that whatever literature is available, it says that it has to be given at least for 1 year to see the benefits of OST. So 1 साल से पहले तो बातचीत करनी ही नहीं चाहिए, वेदर उसको बंद करना है कि नहीं करना है। अनलेस आपका पेशेंट अड़ गया है कि बस मुझे तो 2 महीने 4 महीने ही चाहिए, आप बंद कर दो, वो अलग चीज है। आपने सारे इंफॉर्मेशन दे दी, उसके बाद भी पेशेंट नहीं मान रहे, वो अलग चीज है। बट क्लिनिकली 1 साल तक तो ये बात करनी ही नहीं है कि इसको बंद करनी है, 1 साल तो मिनिमम चलाते रहना है। देन कम्स द क्वेश्चन ऑफ रिकवरी। When will we say that the person has recovered from addiction? The answer to that question is not very simple. Recovery from addiction is not just about quitting illicit opioids कि हेरोइन बंद हो गया है सो हम ये भी बंद कर देंगे, नहीं, that is not the recovery in addiction. Recovery in addiction is much more than that. Recovery in addiction, when we talk about multiple aspects of life. Addiction is associated with dysfunction in the multiple domains of life, be it social, familial, legal, personal, physical. So when you are kind of starting buprenorphine, your goal is not just abstinence from opioids. No, that is not just one goal. Your goal is the entire life of the patient, that फैमिली में जो जो इश्यूज हुए हैं दे शुड बी वेरी वेल टेकन केयर ऑफ। फैमिली में जो रिस्पेक्ट खराब हुई है वापस से वो आ गई है, सोसाइटी में जो रिस्पेक्ट गई है, स्टिग्मा था, या सोसाइटी में जो इश्यूज आ रहे थे, द रिस्पेक्ट हैज कम बैक अगेन। ही हैज नाउ नॉन ड्रग यूजिंग फ्रेंड जिनके साथ अच्छा खासा घुलना मिलना है। जो लीगल इश्यूज थे, कहीं ना कहीं लीगल इश्यूज भी थोड़े बहुत टेक केयर हो गए हैं। फाइनेंशियल इश्यूज थे, वो भी सारे अब जॉब थी, पहले जॉब नहीं थी, वो अब जॉब भी कर रहा है, वेरी रेगुलर है जॉब में, पैसे घर पे दे रहा है, बच्चों का ख्याल रख रहा है। सो द गोल्स आर वेरिड बिकॉज द एडिक्शन इज एसोसिएटेड विद issues or dysfunction in the multiple domains of your life. So decision to stop treatment comes when all these goals of the treating team has been taken care of, right? It is not just that the patient feels that he has recovered because he has not taken illicit opioid for 6 months. No, that is not the goal. The goal is much more than that. And it is the third important thing is that the decision to stop buprenorphine, who should take it? Whether it is the patient or doctor or counselor or the family members. The answer to this question is that it should be a combined decision of all of you together, that yes, this person has kind of recovered from all of the issues he had because of the substance use. All the complications have been taken care of by the medication. And the most important thing is that the patient and the family members are confident enough that yes, the patient can now live a medication free life. If the patient is not confident, do not stop the medication at all. No, that there is a strict no. Again, if you feel that even today there are stressors in life, there are issues uh, which needs to be taken care of and which might be the reason for relapse, do not stop the medication yet. You need to work a little bit more. Finally, you also have to give the information to the client that we might taper buprenorphine, but that doesn't mean your treatment is over. Treatment is much more than that. We already discussed about it. So your psychosocial interventions, despite stopping buprenorphine, will continue. Another important thing that you might need to consider is that uh, stopping buprenorphine because patient is recovered and the patient will not take substances, it appears very good on paper, but it doesn't happen on in practical. Almost that if you see the data from world over, almost 50% of your clients would relapse within 1 year after you stop your OST. So when you are discussing about stopping buprenorphine, person should understand that he is at a higher risk of relapse despite living a drug-free life for maybe 4 years, 5 years, or 1 year or 2 years. There is a risk of relapse, and risk of relapse is never zero. So do remember this always. Do stop your medications very cautiously. If it is not a problematic thing, now there is a take home. So maybe continue with the take home dosage rather than deciding to stop the medication, because it might happen that your client would come back in next 1 year with relapse, and he might have lost all the benefits which were accrued over 4 or 5 years of OST, and there would be probably more complications, because now the family members will also feel that despite the medications for this many years, he has not improved. He is just an addict as of now. So think a lot before deciding to stop medications for any of your clients. uh, Try to give it for as long period as possible. Buprenorphine is not going to harm your clients. The side effect profile is very less. The side effects are mostly related to the underdosing or overdosing. Otherwise, if you give an optimum dose, your patient should be fine, even if you give it for 5, 10 years, 15 years also. So maybe for most of your clients, you might have to provide this medication for a long period of time. For some clients where it is not feasible at all, and you are reasonably sure that you have achieved all you could while on OST, you can consider stopping the medication. When you decide stopping the medication, it should at least take 3 to 6 months to come from 10 milligram to zero dose. It takes a long time, right? And even after stopping, the treatment would continue, psychosocial interventions would continue, follow-ups would continue, right? So do remember this. Am I clear on this? Any doubts, any disagreements, or any questions on this? Anyone? Yes, please, Dr. Mahesh. Dr. Mahesh, you raised hand. Please go ahead.
I've been informed by the staff that we have medicines for the next 3 to 4 days. What do we do after that?
See, again, that is a clinic. That is not a clinical issue. It's an administrative issue, and this question should be answered by probably Mung in a better way.
Because I'm not involved in procuring the drugs. I'm
Definitely.
just there to monitor the dosing of the patient. So
I agree with you that it is an issue when suddenly the supply is stopped, and it should never happen. Especially with this medication, it should never happen. So, but I think your NACO people and TSU people are here, so I think they can take note of this and maybe discuss it further, how to kind of deal with the supply issue. But here we are primarily concerned about more of the clinical aspects. Consider that you have all the dosage in the world. It is not going to be stopped at any time. What would you like to do here? That
Sir,
is what.
Regarding what you have explained just right now,
Yes, please.
we should continue it for as long as possible.
For as long as possible, yes.
For as long as possible. That means we are trying to say that once a person is dependent on any substance, he is dependent for lifelong. He cannot be abstinent from a particular substance.
Definitely, we consider this as a chronic relapsing remitting illness, which even will continue for the rest of the life. We also say that once one has developed addiction, the addiction would continue, right? Relapses might be there even after 4 or 5 years of complete abstinence. We have seen people who have relapsed even 20 years after stopping the drug completely. So definitely there will always be risk. I am not saying that do not stop at all medications, but whenever feasible, the best advisable option is to continue the medications. Otherwise, as I mentioned, that even after 5-6 years of buprenorphine, it is likely that your 50% of the clients might relapse within 1 or 2 years. And you might lose all the benefits you have accrued over that period. So that is what. Once you have explained this, all this risk, and then despite that the patient feels that it is completely fine, there is no risk, you also feel that yes, definitely for this particular patient, there is a very less risk of relapse, you may go ahead with it. But for most of the clients, my suggestion would be to continue it for a long period of time.
Sir, there is another kind of problem which I've been facing over
Yes,
here.
yes, please go ahead.
Since it was this program was started mainly for the IV drug users, so that there's a lesser risk of transmission of AIDS and other communicable diseases, injectable diseases.
Yes, yes.
So people are now coming up who are on oral,
yes.
They are also coming and seeking, and the center is situated at a place which is surrounded by drug peddlers, and it is very notorious for people now increasingly taking brown sugar opioids. So now it is kind of being advertised that कि चलो ना वहाँ पे मिल जाएगा तुमको. And there was one patient just last week, he had come and he brought his wife along with him, and she has started taking buprenorphine. And the dose which we set over here, people are coming and repeatedly, most of them are on 6 to 8 milligrams, you are on 10 milligrams. And of late, because nobody was seeing the center, and since I've been seeing it for the last 2 months, I've been approached by patients कि सर हम लोग का 2 मिलीग्राम बढ़ा दीजिए, 3 मिलीग्राम बढ़ा दीजिए, ठीक है, 2 मिलीग्राम एक टैबलेट और बढ़ा दीजिए. And since we are dispensing it on weekly basis, few other patients have come that कि सर मेरा तो 6 मिलीग्राम से नहीं हो रहा, मगर वो सरदार जी जो थे उनको 10 टैबलेट मिलता था, तो उनसे मैं 2 लेके काम चलाता हूँ. So it is being circulated and distributed, and I think matlab, it is being also sold around.
So there are multiple issues here. One is if you the guideline must have been shared with you all, the revised guideline of NACO, right?
Yes, sir.
See, we are not we don't have a problem with increasing the dose. If you feel that clinically it is required, you can increase the dose even to maybe 16 milligram or 20 milligram or 24 milligram. If your patient is not comfortable, please go ahead with it. Increase the dose.
Okay.
There is no issue clinically. There is no kind of cutoff from the NACO that you should not go beyond this, right? It is the patient. We have always mentioned in the guideline also. It is about the optimum dose, and the optimum dose is different for different people. So always remember, if required, you please go ahead with increasing the dose if you feel that withdrawals are there. But yes, definitely, whenever you are increasing the dose, if you see the guideline, we have kept it there that whenever you are increasing the dose for a stable client, right, who are on take home, so whenever you are increasing, shift them to daily dispensing for at least next 2 weeks. The durations and all, you might refer the guideline which we have created, but start it on a daily dispensing manner. It will give you an idea of twofold, whether the patient requires it or not, right? Patient is really he really have issues. Most patients who really have issues of withdrawals, etc., would agree to come on a daily basis. If they don't agree to it, then please don't increase the dose. Please don't increase the dose if they don't agree, right? That is the important thing.
Thank you.
So whenever you increase the dose, take home should be shifted to daily dispensing for at least 2 weeks. That is one. Another issue you raised was the peddling, right? There are clients who are giving it to other people, right?
Other people.
Yes. So here also, if you see the guidelines, we have mentioned there also that whenever such issues arise, right, you make a
Shift
note
to
in your
daily.
file. You make a note in your file of that particular patient that this person has been distributing it, selling it, or whatever. You give a fair warning to the client that this should not happen again. Maybe you shift them to see whether they require that much of buprenorphine or not. Shift them to daily dispensing. And
Okay.
even after that, if they continue selling it, they continue distributing it, they continue injecting it themselves, right? If that happens, you have a right to shift them to daily dispensing. You have a right to stop their medications altogether. So if
Okay.
there are repeated disciplinary issues like this, you can actually shift them to daily dispensing. You can actually stop their medications, right? So
Okay.
you make sure you inform your all the clients that if there are disciplinary issues, this will happen. Maybe you can fix your own threshold. We cannot give you a threshold. Maybe you can give 2 warnings or 3 warnings or 4 warnings. And after 4th warning, we'll stop the medication. With 1 warning, maybe you can shift them to daily dispensing. Something like that, that you have to decide, right? So those kind of things you might have to think of. But remember, again, I'm telling you that whenever you are increasing the dose, shift your clients back to daily dispensing for some time at least.
Okay. Thank you, sir.
Yeah. Any more questions on this? When to kind of decide to stop the medications? Okay, so let us go to the third scenario. So a client currently on daily supervised OST reports that he feels much better taking the OST medications in 3 divided doses per day compared to once daily administration of the complete dose. What would be your next step? Anyone? What is your view on that? A patient is taking in 3 divided doses, or he says that he feels much better when he is taking in 3 divided doses. What should you do? What is your next step? Anyone? We have only 3 people who are talking about it. Other people, sorry, because
First of all,
most of you are not visible to me, so I am not coming to you individually. But I would like it if all of you can participate a bit in this conversation, because
okay.
yeah, please, Dr. Ashok, right? Dr. Ashok, if you would like to share. Can you hear us, sir? We are not able to hear you, sir. Your voice is a bit...
All, I will give him daily dispensing. Not, I will not give him to take home drugs. Go and take in. Yes, I will not give them. So I will not give him daily dose. I will call him for daily, and I will wait for half an hour. So I will watch for 15 days whether he is feeling better or not. Plus counseling also. Then I will started to give him the take home medicine. He has told me that I
sir, your voice is bit breaking.
but then I feel better. But no, I will not give him the take home medicine. I will give him daily dosing system. So I call him to come to the center and take the drugs daily. And I will watch for 15 days or a month. Then I will decide to give him the take home medicine.
So the thing is, what would you like to observe here?
I will observe, then I will search what he feels, why. If I think he say it may be the dose will be the less when he has taken, so I will first of all I will increase the dose. How
Hmm.
much? Say about I have given him 6 milligram. He has taken 2 milligram, 2 milligram, 2 milligram. So I said, oh no, it
Hmm.
means my dose is less. So I have started from 6 to 8 first, and I will watch for 24 hours. Then again I will call him to come to center. I ask him whether you are feeling better or not. If he
Hmm.
will tell me no, sir, I am still slightly. Then I will start to increase. When patient told me that, sir, now I am fit. So
Hmm.
after that I will decided to go further.
Okay. 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 So, uh, the good thing you told about that, probably the clients who are themselves telling that they are taking it 3 times a day, there are 2 or 3 things which you might have to consider. One is that the dose might not be sufficient. We already discussed about it that with a low dose, the effects last for a short duration, maybe around 8 to 10 hours or 12 hours when you are giving a low dose. And because of this, sometimes the clients they start experiencing sleep disturbances, body ache once the evening comes or the night comes. So the first thing is to ask what happens where they are taking it in a single dose. If they are not comfortable 24 hours for 24 hours at least, it means that your dose probably is lesser than what it should be. It should be increased further till the effects last for 24 hours. Dr. Mahesh is, I guess, trying to say something. Dr. Mahesh?
Sorry, sir, my mic was on. Sir, this this is, I think, like sir has already said, he'll watch him. Definitely, I think he should be kept in 24 or 48 hour observation, and then
Hmm.
only. And if he says that since buprenorphine has a longer half life on higher doses, if he's
Hmm.
on more than 8 to 10 milligrams, it
Hmm.
shouldn't be. He should needn't take it thrice a day. So either it means his requirement is very high,
Hmm.
or the next thing which I was pointing out is he's peddling his drugs.
Hmm. Yes. See, I agree with you that peddling or selling happens, but it is actually not that frequent. So always think probably on the lines of maybe the client is not comfortable enough. Many of time, what happens is uh, that patients are not taking the whole dose because they are kind of keeping the stock, some stock for emergency situations. There will be clients who would not be able to come daily or every week for indefinite period of time. So they try to keep some stock available for a later use. So that also happens quite commonly. So you ask them that whether they are doing this, they are keeping some dose for future use. Because when it comes to prescribing or buprenorphine giving extra doses, say for someone has to go outside, we are not that lenient when it comes to giving buprenorphine. So patient themselves they keep some dose for themselves. Another thing is uh, especially when we are providing take home medication, there will be clients despite all your efforts they will say that नहीं मैं तो घर पे 3 बार में 2 बार में ही लेता हूँ. What should be your approach? In my opinion, maybe you can give them the message that no, it should be taken once a day. There is no doubt about it. There is no doubt about it at all. But the important thing is, whenever you are coming to me once a week, the medication will be given in a supervised dose as a single dose. It should not be given like he is taking 2 milligram morning, 2 afternoon, 2 evening. You have to give 6 milligram on that particular day as a single dose. Many of the clients would say नहीं नहीं मैं तो 2 मिलीग्राम ही सुबह लेता हूँ, मुझे 2 मिलीग्राम दो, बाकी के 2 मिलीग्राम मैं बाद में खा लूंगा. नहीं, right? So this will also give you an indication after taking 6 milligram if he is intoxicated a lot maybe, है ना, sedation हो रहा है, drowsiness type हो रहा है, dizziness हो रहा है, that also gives you an indication that probably he is not taking it the way it is prescribed, or he's not taking it in a dose which is prescribed. He's taking less, so it might give you an indication also. So that here two things are there. One, always, even in on the take home patients, if even if the person is taking it in 2 or 3 divided doses, the supervised dose has to be taken in a single dosage. And second, always look for possible withdrawals. Even it happens that even during your maintenance stage, right, there are three phases of OST. There is an initiation phase, there is a maintenance phase, and then the termination phase. It is possible that even during your maintenance phase, the patient might develop some withdrawals, especially people who have now started working. Say, for example, they were unemployed before, they have now started working. They are involved in heavy labor work, or they have started ART medication, or they have started HCV medication, anti-epileptics. You might have to consider that there might be an need for increase in the dosage, because the same dosage might not be effective. So this is something you should take care in mind. The fourth scenario is a 45-year-old client, opioid dependence, tobacco dependence, presents with a complaint of fever, cough, shortness of breath, COVID-19 infection is suspected. What do you do next? क्या लग रहा है? What should you do? I think this is the simplest question, but common clinical situation, I guess. Maybe not just about COVID-19 infection. It might be any major medical comorbidity. Say, for example, someone has a fractured leg and got admitted. Someone has a surgery, has to be admitted for 7 days. What should you do? Anyone?
Tuberculosis test for
Where-
tuberculosis.
Okay.
Dr. Ramesh, please go on, sir.
Test for tuberculosis.
Okay. But regarding the OST, what would you like to do? So this is whether to consider take home here or not. Let me clarify it further.
Because we are giving daily dispensing on supervised dose, so I don't have any idea regarding take home when
Acha. So you do not have a take home facility at your center?
No, we have facility, but we are giving it to very restricted people. We are insisting on daily dispensing. If somebody has to go somewhere else, if somebody is having fever, is somebody is admitted in hospital, then only we are giving take home. Otherwise, we don't.
Okay. But we have actually kind of rolled this take home doses, right, with COVID-19 infection, and the take home dosing is still continuing for the stable clients.
No. We have stopped at the time of COVID when the special instructions were there for COVID-19 take home. We were giving. Otherwise, we have stopped giving.
Okay.
Take home. We are very strict, not very easy. Not we take easy.
Okay.
Yeah.
Any specific reason, sir, for being too strict with your patients?
Just like the peddling and misuse.
Okay. So let me come back to it. So what do you all think, that whether take home should be given or not? Should take home be given for buprenorphine?
Mostly patients are not reliable. They are unless until proved and they are criminal, or they are not so sober patient in society. So I think, in my opinion, they should not be allowed to take home. We should dispense at the center only.
Okay.
Sir, may I speak?
Please, Dr. Sujit, right?
Yeah.
Please, sir, go ahead.
suspicion, sir, is not good enough. I think the patient would require a referral first. And once we are sure regarding that with a RT-PCR, then I think we can give take home for that period. Now, as per the guidelines, minimum 1 week of confinement is good enough. So I think take home medication for that period should be allowed. That's how I see it.
Okay, okay. So you want to give take home, right? If it is COVID, confirmed COVID infection and isolation is required. Okay, so the bigger question here is whether to give take home to clients or not, right? We have some dividing opinions that different opinions that take home should not be given because these are not clients who should be trusted, right? What do others think? Dr. Mahesh? Yes, please go ahead.
Sir, basically, this program was started to reduce the effects of injectable drug users. The side effects or the HIV infection which was acquired using the single needle by these patients. So I think it should, if the person is actually on IV drug user, is a heavy IV drug user, and he is at a risk of infecting himself, and in the process infecting others also, in his family or in his community. So this program was what I know is this program was started because just to reduce this effect, and gradually it has been expanded, and now we are giving OST to oral users also.
Okay. We have not started it for the oral users. Still, the programmatic requirement is that it should be, it will be given only to the injecting users.
Actually, I didn't go through the manual fully.
Okay.
I was informed with.
So you are right in a way saying that the program requirement is that it would be just for injecting drug users so that we can reduce the risk. But as a strategy, it is not just kind of included here for reduction of HIV risk. It is for much more than that. We are here for providing treatment to patients who are suffering from addiction, right? Now the question arises whether a take home should be given to this group of patients or not.
Sir, may
I think, sir, please, Sujit Naik ji. Sir.
I just want to add one thing. I'm a little bit skeptical with regard to dispensing medicine for as take home. So the only thing that I'm worried about is that because the alcohol because the dependent patients are not as disciplined, and we know the extended support that they have or the family support they have is too much in disarray. Usually take home medications do not work. I mean, that's how my practical experience says. So I'm actually skeptical regarding doing that, and because the people are not very disciplined, which is the package of a dependent patient, I would still would prefer daily dispensing, making that and like lifestyle with the patient that they would the lifestyle of the patient that they would discipline in their life, which would help them more. So daily dispensing still would remain a priority for me. I would not like to dispense the take-home medications for until and unless exceptions. Of course, like you said, COVID infection may be a dire emergency when the patient actually genuinely we know from the family members that they have to go someplace. Otherwise, I would feel daily dispensing would be better.
Okay, okay.
Thank you.
So this is great. You share your experience. But let us talk about two or three things, right? First of all, we think that daily dispensing is a better option than the take home for this group of population. But why? We have data from almost the entire globe, different countries, that take home medication is really essential for client retention, for better outcomes. With take home, people actually improve much more than the daily dispensing. For daily dispensing, the patient has to be from maybe 3, 4, 5 kilometer catchment area. Otherwise, patient might not be able to come. So take home actually helps to cater to clients who are actually might not be able to come because of the criteria of coming daily, right? That is
Agree.
one thing.
Agree.
So overall, if you see, take home is a very good option, and it is used across the globe. It is not something NACO has started for the first time. No, it is given across the world in NIMHANS. They give 30 days of take home, or for some clients 6 months of take home also. So here, what I see, I guess, even when we are seeing these patients, we are not seeing them as patients. They are bad people who are criminals. They will, almost all of them will sell medications. They are here just to kind of divert the medications. I think we also needs to uh, kind of change a little bit of our myths and misconceptions also. When
No,
you
sir.
see criminality,
No, sir.
uh,
Actually, I'm not taking that into angle. Although the antisocial traits are definitely there, I agree to that. But the trouble with this would be the psychosocial intervention that we actually talk about is very poor in our country, and it is actually not practically happening. You know, like from center to center, and otherwise also when I was in a bigger center also. This is what I see, that psychosocial intervention,
I
although we talk
definitely
about.
agree with you. In a way, that daily dispensing also has advantage, right?
Yeah.
The question is about the clients who are doing quite well now, who have reached the clinical stability. I hope you must have the new revised clinical practice guideline, which has an entire section of take home dosing. So we are not giving take home to people who are diverting the medications. No, we are giving it to a specific group of people who have developed a clinical stability, who are not, who have no disciplinary issues, who are ready to follow our rules and regulations, who are ready to follow up regularly, who are doing good work now, who are employed, who are contributing to their family, who have stopped using the substances. So this group of people, why not to give take home? Why to unnecessarily kind of bother your clinic with just providing medication which can be taken at home also, right? The question, next question comes, what if the patient starts diverting, right? We are all concerned about diversion, but uh, whatever the program experience is from across India and from across the world, there will be a subset of patients. Definitely, there will be subset of patients who will divert it. There will be subset of patients who would inject it, but it is not as high as we think. That no, not 100% of them are criminals. There are few who are criminals. There are few who are actually engaged in criminality because of the substance use. Now, substance use has been taken care of your by medication. You yourself are saying that uh, they have become better. This medication helps them become better. The complications are well taken care of by the medications. So, for that group of patients, why not take home to be started? Why to unnecessarily kind of है ना, create a lot of crowd in your center when that medication can, and it also helps in the retention. It actually improves your outcome over the long period of time. And as I already mentioned, that this is a medication which needs to be given for a long period of time, maybe 2 years, 5 years, 10 years. Who can come daily for half an hour, 1 hour, spending some money to bus or auto or so there is a human aspect as well, right? So there are multiple things, but if you see clearly the guidelines which we have provided now, that it is there, you should start take home for clients who you feel are relatively better now. They have achieved clinical stability and we have defined it very beautifully. We are not saying that you give it to each and everyone. No, that is not the thing. We are not going to give it to each and everyone. We are going to give it to people whom we also trust now, who are much better now. Their family function has improved a lot. They are working. They are going to job regularly. They have stopped taking buprenorphine. Start take home for them. If once you have started take home, if there is an issue, you might come to know that this person is diverting, this person is injecting. You will come to know. There will be out of 100, 2 or 3 people will be there, right? You can stop take home for them. There is a provision for that as well. So here we have a kind of thought block for us also, that what will happen if we start take home, everyone would be start diverting it. No, that doesn't happen. AIMS New Delhi has been giving take home for years. There are almost 200 400 clients who are on take home medications and they are doing pretty well, right? So we also need to kind of take a step forward and start giving take home, see for ourselves whether the take home works or not. So that is my take on it.
One thing, sir, one thing.
Yeah, please go ahead, sir.
We are not. I'm not having any circular. What you are talking regarding so much reluctant about take home medication.
Okay.
So where can I get this circular?
Okay. Moon, would you like to say something here?
Yeah. Yeah, Dr. Ramesh. Earlier we had circulated take-home guidelines and then the new revised guidelines, but we will recirculate it. Okay? We will recirculate it for everybody here. So
I think NACO should categorically write this, that this practice of take-home has been considered and to be continued even after COVID. And the guideline should be shared again, because this is the query even during the last session also was there, that it was just for the COVID period. No, it was not just for the COVID period. Take home is here to stay, right? And this is the way forward.
So I haven't got the circular regarding this, sir.
The circular regarding
this continuation after COVID. Take home should be continued even after COVID. So I will ask my state authorities.
Okay, okay. So Mung, if you can share the guideline again during this time only, that this clinical guideline, it has been revised, and we'll be talking about that during the future sessions also. So it would be better.
Yeah, we'll do that.
Okay. So
thank you.
Rest assured, sir, this guideline has been implemented, and there is nothing like we have stopped take home from the NACO side. It will be continued, and we have actually developed an entire revised guideline. We have a very specific section on the take home, for whom it should be considered, for whom it should not be considered at all. So we have an entire section, and it would be again reshared with you.
Okay, sir. Okay, thank you.
Yeah. Ramesh, whether induction, this OST training was conducted there in your state?
Yeah. Not recently, but about 2 years back, induction was.
2 years back. Okay. But there was this trainings, OST training on this revised guideline, which is going on for almost all the states. Mung, is it pending for this state?
I don't know what.
If Moon can share.
Yeah, Rameshji, you are from Chhattisgarh.
Chhattisgarh.
Yeah. I think Chhattisgarh training was already conducted with this same other states, Bihar, Jharkhand.
No.
Or is it with Odisha? I'll have to
No,
check.
no, no,
But
no. Not recently, not recently.
No, no. With Odisha, Jharkhand people were there.
Odisha,
So,
Jharkhand.
as far as I am aware, MP has done it. Jharkhand and West Bengal and Odisha has done it. I am not sure of UP and Bihar and Chhattisgarh.
Chhattisgarh was one of the first to have done it actually. Okay, maybe Doctor, maybe I'll just check. I'll just check.
Okay,
Thank you,
okay.
sir.
So
Thank
I
you.
think because okay, so I now can feel why there is a doubt going on, because probably some of the state might not have done this particular training. Most of the states are doing this OST training on the revised guideline also now, in which there is a entire session on the take-home dosing as well. So if it is not done yet, maybe it will be done soon in your state also.
Thank you, sir. Thank you.
Yeah. So any questions on this for take home? Anyone who might not agree with me, it's okay. We might have disagreements. This is my view. This is what NACO views take home as now. But any different opinions on this? I do definitely agree when you say that there would be clients who are difficult clients who would be doing some sort of naughty things and they'll start selling, but that population is less, and because of that you kind of the entire other people are suffering. They are not being provided take home. So and the major reason for kind of diversion also is probably non-availability of buprenorphine in most of the regions. Matlab, it is not available as much as should be available, as near to them as it should be available. So someone shared about it some time back that एक पेशेंट को थोड़ा कम मिल रहा था या नहीं था तो दूसरे पेशेंट के से खरीद लिया. So it is more like है ना, medication which is not easily available, they have to take it from someone else, right? So I think it's a fault from the government side also that they don't have availability of buprenorphine to an extent which it is required. Any questions or disagreements or anything on this particular take home thing?
Sir, agreed for exceptional clientele, definitely. Not as a cloud.
Not as a?
As a cloud, like not as a blanket statement for take home, like you said. That's
Definitely.
what I would.
So,
and clientele differs from place to place. So
exactly.
with those stable where we have very good support from the family and supervision, which is almost zero in most of the centers. Like that's how I see in my center. I don't see any family connection, family contact. The TIs are actually trying very hard, but then they don't manage to it. That's the practical scenario. So
definitely. So I am not saying blanketly that provided to all the people. No, that is not the case. You assess the client, you see if they are meeting that stability criteria or not, and based on that you decide whether you want to give it or not. Definitely the final decision will be yours. But at least there will be some clients, there will be 20, 30, 40% clients in your OST center registered who are quite doing good. For them, you don't have to worry much about providing them medications daily at your center. And it will also help decongest your own OST centers. So it is some way helpful for you also, some way helpful for other clients also who are not coming because of the crowd, because of the waiting hours. So overall, it will actually benefit your overall retention rate, your overall outcome of the OST center per se. Okay, so the last case scenario is a client on take-home OST followed up at the OST center after 2 weeks. He claims taking buprenorphine given to him regularly. How to ascertain his claim and assess if there is loss of tolerance in the individual due to change in the pattern of substance use. So before having a discussion on this, I'd just like to add also that if you remember, if you have not received the revised guideline, but we had also shared the COVID guideline, the take-home guideline during the COVID period also. This entire take-home criteria is almost the same. It has been developed by us only, so it is almost identical. So if you have that also, you can go through the take home particular part and you can decide if some of your clients meets those criteria or not. But definitely I am hoping that Mung will be sharing that particular guideline in next 1 or 2 days, and things would be pretty clear after that. I would request each of you to go through that particular take home section. It is of 2 or 3 pages only. It should not take maybe more than 10-15 minutes for you, but just go through it once. And yeah, Rameshji, are you trying to say something?
No, it's all right. It's all right. I will go through it and I will find it. No problem.
Okay. Yeah, thank you. So this case scenario, what do you think you can do when someone is on take home and buprenorphine is being given to him? He claims he has been taking it regularly. So can you assess him whether he is taking a buprenorphine as prescribed? How do you do it? Anyone? This is the last question and then we'll end this particular session. Anyone?
No comment, sir. No comment. Can't answer. Can't answer this question.
I think we are doing this day in, day out for the take home clients. Sujit ji, Ashok ji. See, let just let me explain it and then maybe we'll wind up the session. The simple thing which I have already talked about, that take home doesn't mean that we won't be giving supervised medication. Take home means that one day the medication will be taken in front of you in a supervised manner. For next 6 days maybe they will be taking it at home. So if someone is not taking it as prescribed at the day of your own supervision, definitely once you give the exact dose in a single dosage, there will be some signs of intoxication. If he is not taking it at the usual dose, there would be some signs of intoxication, dizziness, or maybe some nausea, maybe some sedation, and this might actually help you to ascertain if the person is actually taking the medication as prescribed or not at home also, right? So this is a simple thing which we actually do day in, day out, right? So beyond this, if any questions, any last minute questions or some queries, I'd be happy to answer. Any questions?
Sir.
Yes, please go ahead.
Sir, actually, this is the first time I've been associated with OST. In CIP, we are a strong advocate of complete abstinence and then harm reduction and then substitution therapy. The goal over here is, once a person who is on heroin, brown sugar dependence, and we shift him to buprenorphine, as you said, that it will be for a long time. Assuming that that person might relapse at some point of time, maybe 1 year, 2 year, 3 year, 4 year, and 5 year. Is it for all cases of addiction, or is it just for opioid?
Usually we consider this for almost all the addictions, but the duration, say for example, even alcohol. However, for alcohol, we usually have studies which say that disulfiram should be given for 1 or 2 years. But even after 1 or 2 years of disulfiram, there are
Okay,
relapses. There are
disulfiram treatment is a different modality of treatment.
Yes.
And the person is willing not to take alcohol. In that
Mhm.
cases, we give disulfiram.
Mhm.
है ना? But what if he has a problem sleeping? A person on alcohol dependence per se. What if he has problem sleeping? So should we prescribe him a benzodiazepine for a longer duration?
No. Benzodiazepines does not fit the criteria of agonist maintenance. The specific candidacy, for example, the duration that it should be free of long-term side effects. There should not be major side effects. Those kinds of things. It should be very well taking care of all the cravings and withdrawals, etc. So it does not fit the bill for the ideal agonist medication
not
for
the only
alcohol.
we cannot make a person completely abstinent on single drug on alcohol.
Mhm.
Luckily, we have something for buprenorphine, for opioids. So are we labeling the person as a dependent? Aren't we stigmatizing that person? कि तुम अब तो ले लियो, अब तो तुम छोड़ ही नहीं सकते हो.
Definitely not. We are saying that this is an illness which is a chronic illness, and it has a relapsing remitting nature. So we are not stigmatizing. We are saying that this is a chronic illness which will go on for a long period of time. So we are not putting the blame that you are taking it. We are giving
him support so that he is functional.
Yes.
The ultimate goal of any kind of treatment in psychiatry is the person achieves complete functionality.
Definitely,
He
yes.
is having hallucination and he is working properly. So we wouldn't go for clozapine higher doses to control his hallucinations and just making him sedated. So that wouldn't be a very prudent approach. So in case of substance, what if a person is taking substance and he is achieving complete proper functionality? My question goes back to the first point, which was I was putting again. Why shouldn't we think of tapering the dose once the person has achieved remission for a period of time, certain period of time? Because it has not been stated in any literature when we can say the person is completely abstinent, because it has a relapsing remitting course. And now the problem which I'm faced currently, complete shortage of buprenorphine. How am I going to handle that? People will be shifting to brown sugar again. All my questions.
I agree. So because you give the example of schizophrenia, so if someone is on clozapine and has been doing fine, we do not think of stopping clozapine at that point of time, because there is always a risk of relapse after even stopping clozapine. We actually continue it for a indefinite period of time. That is there with all the antipsychotics also. Here also we know that there is a high risk of relapse. There is a risk of relapse of almost 50% in next 1 or 2 years. So that is what I am talking, that it needs to be continued for a long period of time, just like any other chronic illness medications. That is what I am saying. Stopping it, again, it might not be a very prudent thing to stop it for all clients. Definitely there would be some group in which you feel that yes, we can think of stopping, please go ahead with it, right? But it has to be a mutual decision. I'm not saying that don't stop it for anyone. No, that is not the case. I am saying that whenever you decide to stop, it has to be a decision, mutual decision of yours, the clients, everyone should be on the same table about it. That is what I'm saying.
इसका 25.
Yeah.
Okay, thank you, sir.
Yeah. So I guess over to Anushri and Moon.
Yeah, yeah. Thank you very much, Dr. Arpit. We have almost reached 6 p.m. So we would like to close. But especially today, I think I would like to thank all the doctors who attended this meeting. We started with 8 doctors, all of them attended. Now we are 3 of them left after after the discussion. I think around 5:30 or something like that. But still, we have Dr. Mahesh, especially, and then Dr. Sujit, Dr. Ashok, Dr. Ramesh, Dr. Munish, and then Dr. Priscilla. And then it was a good interaction, and then it was a good discussion. I would like to especially say to Dr. Mahesh, because Dr. Mahesh is a nodal officer in Jharkhand, and in Jharkhand we have two we do not have medical officers recruited, and we have nodal officers, 2 of them, and then Dr. Mahesh is one of them. And we are very much the program in Jharkhand is very much dependent on Dr. Mahesh. So Dr. Mahesh, I believe there was a training conducted with Orissa and Jharkhand, and then another one Bihar and Chhattisgarh in December. Maybe you were out of station, maybe.
No, sir. I I've joined OST. Matlab, I was given an
Recently.
additional charge of OST just 2 months back.
Okay.
Dr. Giri was looking after everything, and
Okay.
after I have joined, CS sir has told me to look after OST. I've not been given any formal letter of year.
Okay.
So
Then, sir,
I'm just looking after the patients. Yes, sir.
Yeah. So, sir, anyway, we are happy that you are here now. And then Dr. Amit, Dr. Arpit, and all our technical experts will be in touch. And we will keep all of you in the OST medical officers group of NACO, so that there you can raise any questions or issues that come up. And then if any additional training is required, also we will look to conduct that. And another thing regarding your medication, thank you for bringing it up. Currently, actually from NACO, we are doing a local procurement where the states are authorized to do local procurement. So we will raise it with the Jharkhand SEC, and then you can also talk to your JDTI at Jharkhand. I will also talk to them, and we'll look into it. And then, like Dr. Arpit has said, we will send you the take-home guidelines and the revised OST module in your email IDs, and we will send it to in the WhatsApp group also. And what else? So thank you all for attending. Once again, the OST program in your respective states is very much dependent on the medical doctors. So thank you for attending, and we hope to connect with you all again through the WhatsApp group. And thank you, Dr. Arpit.
Thank you, Mung, and thank you, everyone. Have a good day.